Welcome to the Radiology Review podcast, your on-the-go source for radiology education with your host, Dr. Matt Covington, a board-certified radiologist. Please follow the podcast on Twitter at RadRevPodcast. Send emails to theradiologyreview@gmail.com or visit the website theradiologyreview.com.
Let's go on to pycnodysostiosis, Pycnodysostiosis, pycnodysostiosis. This is an autosomal recessive condition. It does cause some dwarfism, and with this you get very dense but fragile bones and acroosteolysis, underdeveloped sinuses and mastoids, and a straightened appearance of the mandible and micrognathia, which means the lower jaw is undersized. That's MICRO, micrognathia, GNATHIA. Another name for this is Toulouse-Lautrec syndrome. There's some interesting history there, so if you don't know that, look it up. If you can only remember one thing with this, I would remember dwarfism with osteosclerosis. I guess that's two things, but that's it. And then go ahead and look up pictures of Toulouse-Lautrec syndrome, and once you see these images, you'll help remember this disease. Now, there's a laundry list of things associated with this, some of which I mentioned, but one of these that's worth mentioning further is Wormian bone, which is spelled WORMIAN bone. And these bones are additional small bones that are sometimes seen between cranial sutures, most frequently around the lambdoid suture. If you have too many of these, it can be considered abnormal, and these Wormian bones are often related to things like pycnodysostiosis I just mentioned, rickets, osteogenesis imperfecta, the disease I mentioned first, Hadge-Cheney syndrome, with the acroosteolysis association and other things. For Wormian bones, there is a mnemonic called pork chops, P, pycnodysostiosis, O, osteogenesis imperfecta, R, rickets, K, kinky hair syndrome, C, cleidocranial dysostosis, H, hypothyroidism/hypophosphatemia, O, otopalatodigital syndrome, P, primary acroosteolysis, which is Hadge-Cheney or progeria, and S, syndrome of Downs. Some of these mnemonics work well, others don't. This one didn't do the best for me, but maybe it will help you, so I've mentioned it for your benefit. Let's move on to Gardner syndrome. This is osteomatosis, where you get multiple osteomas, which appear on imaging as densely sclerotic lesions, as well as multiple polyps. This is a commonly tested condition. You have, I understand, about 100% involvement of the colon, 90% of the duodenum, and this is also associated with gastric hamartomas, osteomas in the calvarium, mandible, and sinuses, which can, in severe cases, lead to entrapment of cranial nerves, and eventually in the lifetime 100% risk of malignant transformation. For this, the most important things to remember are the familial polyposis and the multiple osteomas. There are other things associated, such as desmoid tumors. And remember, this is autosomal dominant. I definitely would remember that, and associated with the FAP gene. Let's move on to osteopoikilosis. This is associated with multiple epiphyseal enostoses. And you're starting to see with these syndromes how I'm just bouncing around between different organ systems. Many of them have MSK and GI and neuro manifestations. Therefore, these end up showing up on exams because you have multiple opportunities for a different section to ask you about one of these. With osteopoikilosis, you end up with multiple benign enostoses. This is often incidentally detected on a skeletal x-ray. And again, I said these are benign, so that's one thing they want you to be able to realize, is that this disease is not something to confuse with malignancy. It is one of the don't touch lesions. And when we're talking about enostoses, that's a fancy word for incidental bone islands. Okay, in this case, you get just a lot of them. Osteopoikilosis is an autosomal dominant condition, and this is one of the don't touch lesions, similar to others such as the tug lesion or cortical desmoid, Pitt's pit or the synovial herniation pit, bone infarctions, unicameral bone cysts, non-ossifying fibroma, and so on. Let's move to multicentric reticulohistiocytosis. This has a similar radiographic appearance to gout and rheumatoid arthritis. You end up with nodular swelling, erosions of the joint, which are distal and symmetric, but in this case there is no periarticular osteopenia as you would see with the inflammatory arthritides. That's all I'm going to say for that one. Alkaptonuria, ALKAPTONURIE, is also ochronosis, which is a homogentisic acid deposition disorder, and for this, remember the intervertebral disc space calcification is key. This is autosomal recessive, and you also get sacroiliac joint arthropathy. Really, the key for alkaptonuria is to remember this is also ochronosis, and the more classic thing they will show you is the intervertebral disc space calcification. This is not the only cause of this, but it is one that is commonly tested. And with this, you get very dense central nucleus pulposus calcification that usually starts lower in the spine and then ascends superiorly. Let's move on to Menkes syndrome, MENKES. This is associated with osteoporosis. It's a copper transport disease. With this, remember it is an X-linked recessive disorder, which makes it more unique, and this results in low copper levels, which causes problems. Look in the question stem for silvery and brittle, kinky type hair and progressive neurologic deterioration. On imaging, you'll see some musculoskeletal manifestations, including metaphyseal widening of the femurs, Wormian bones that I described before. On neuroradiology images, you can look for progressive cerebral and cerebellar atrophy. And one interesting thing with this is that Menkes disease can mimic non-accidental trauma, where you get these bilateral subdural hematomas and possible retinal hemorrhage, and that's something I would be aware of. Let's move on now to Milkmans syndrome. This results in osteomalacia with looser zone stress fractures. Classic locations of involvement are the outer scapula and inner femoral neck. And remember, if you see the looser zone stress fractures, that tells you this is osteomalacia, not osteoporosis. Let's talk more about looser zones. Other terms for this are Milkman lines or cortical infractions, and these are wide lucencies in a transverse orientation that travel partway through a bone at a 90-degree angle with the cortex. Like I said before, this is associated with osteomalacia, and you'll commonly see this with rickets. Look to see these in a symmetrical pattern in classic locations I described, such as the lateral aspect of the scapula and the proximal medial femurs. Let's move on to tuberous sclerosis. There's a lot here, and you are definitely going to see questions on this one, so make sure you know tuberous sclerosis when you show up for the core examination. Tuberous sclerosis has an association with cardiac rhabdomyomas, renal angiomyolipomas, cortical and subependymal tumors, as well as subependymal giant cell astrocytomas. This is one I could probably spend an entire podcast on, but I've covered the main ones there and told you to spend some time on tuberous sclerosis. This is a phakomatosis, and it causes multiple tumors, the most common of which you will be tested on are the cardiac rhabdomyomas, renal angiomyolipomas, and the cortical tubers. Clinically, these patients tend to have seizures, intellectual impairment, and this classic adenoma sebaceum, which are angiofibromas that you see as red papules on the face. Let's move on to Caroli's disease, Carolis. This is also very commonly tested. It is autosomal recessive, and you end up with segmental cystic dilatation of the purely intrahepatic bile ducts, which is the same as a type 5 choledochal cyst. Unfortunately, you do need to know all the types of choledochal cysts. I'll try to cover that later, but no, Caroli's disease is the type 5. This is of unknown etiology, although autosomal recessive, and you have a problem with this that you get bile stasis, which can end up causing extensive calcifications and lead to secondary pyogenic cholangitis, which then leads to intrahepatic abscesses, and that chronic inflammatory state can elevate your risk of cholangiocarcinoma. This has association with medullary sponged kidney in about 80% of cases, infantile polycystic kidney disease, and on imaging, you can look for multiple cystic dilated structures that converge towards the portohepatis. A classic sign for this is a central dot sign, where you see the portal radicals surrounded by cystic bile ducts. To be more specific, Caroli disease is technically dilation of the large intrahepatic ducts, and Caroli syndrome has small duct involvement and hepatic fibrosis. Also, although I typically remember the association with autosomal recessive polycystic kidney disease, this also is associated with autosomal dominant polycystic kidney disease, so you get both types there. In terms of imaging, they will show you something to whether ultrasound, CT, or MRI to show the dilated intrahepatic bile ducts. And remember the central dot sign where you see enhancement within the dilated intrahepatic bile ducts from the portal radicals. Content of this podcast is provided for informal educational purposes only for radiology trainees and radiologists. Medical practitioners, please make your own independent assessment before suggesting a diagnosis or recommending any course of treatment. This podcast should not be used for self-diagnosis or self-treatment and is not a substitute for independent professional medical care. Please consult your own physician regarding any diagnosis, imaging interpretation, or course of treatment.